Welcome to the Healthcare Executive Podcast. I'm Arindama Rajan. I want to start with a small, almost throwaway detail from the conversation you're about to hear because I think it explains everything else in it. At one point, my guest is telling me about evaluating an AI based ultrasound device for one of his hospitals. The vendor's making the usual pitch: portable, powerful, works anywhere. And my guest says, "Leave the device here. Come back in 2 days. Don't touch it." So the vendor leaves. 2 days later, he comes back, and there's dust on the machine. Real dust, because this is India, and not every corridor is climate controlled, and the air doesn't ask permission before it settles on your equipment. My guest tells him, "Don't clean it. Turn it on exactly like this and show me it still works." That's the whole philosophy in one scene. Not, does the technology work in a lab in California? Does it work in the dust? His name is Sarjeet Thakur. He's the co-founder and CEO of a health tech company called TrioTree Technologies. And this is the part that still surprises me. He is at the same time the chief information officer at two hospitals, Rajagiri Hospital in Kochi and Sri Shankara Cancer Hospital and Research Center in Bengaluru. Not one after the other, simultaneously. He is not a vendor who drops in with a slide deck. He is inside the building, living with the consequences of his own recommendations on a hospital floor in real time. Here's how he got there, and I want to tell it the way he told me, because it's a much better story than the version that usually gets written up. He passed out of engineering college in the year 2000, which happened to be the year of the Y2K scare, when every company doing IT hiring in India froze because everyone was busy firefighting the millennium bug. So his campus placement got delayed. He was sitting at home, a computer engineer with nowhere to go. And more or less by accident, he landed a traineeship at Max Healthcare. He remembers people asking him, "You did computer engineering. What are you doing in a hospital?" And somewhere in answering that question to himself again and again for 25 years now, he became a healthcare IT person for life. He has a word for it that I hadn't heard before this conversation. He calls himself a healthpreneur. There's a second origin story buried in there too, and I think it matters just as much. Years later, working at Dell, which had acquired a company that was implementing a large American electronic health record product across a big Indian hospital chain, he and his eventual co-founders looked at that US-built software being force-fitted onto Indian hospitals and asked a very simple question: why don't we build our own? That was 2011, before Make in India was a slogan anyone had coined. They started in a 6 by 6 room. No funding, no investors. He's very particular about this point, that they bootstrapped it because it was driven by passion rather than a pitch deck. That 6 by 6 room is now a company that by his own account has crossed 100 crores in revenue. Running hospital systems he still operates with his own hands on the ground. I want you to hold on to one more image before we get into the conversation properly, because I think it's the clearest evidence I've heard of what all this actually adds up to for a patient. At Rajagiri, a 600-bed hospital running at over 90% occupancy, discharge used to take a cash patient more than 3 hours from the moment a doctor said you can go home to the moment they actually walked out the door. Because 7 or 8 departments, billing, insurance, nursing, pharmacy, the blood bank, all had to talk to each other, mostly on paper, mostly in sequence, mostly invisibly to the family sitting in the corridor. He built a real-time dashboard, green, amber, red, visible to every department at once. That 3-hour wait is now down to about 75 minutes, and he told me they're still trying to bring it down further. Nobody puts that on a hospital's annual report cover. Nobody photographs a discharge dashboard. But if you've ever sat in a hospital corridor for 3 extra hours after being told your father can finally come home, you know exactly what that 75 minutes is worth. We spoke for close to an hour about his journey from that stalled campus placement to running two hospitals technology at once, about what digitization actually means versus digital transformation, and why those are not the same word wearing different clothes. About why he thinks the story that doctors resist technology is, in his words, a myth, about billing transparency, artificial intelligence in Indian wards, and why he believes the next decade of health tech won't be imported from Silicon Valley. It'll be built here, in the dust, for scale nobody else in the world has to survive. Here's Sarjeet Thakur.
You had a very interesting journey, right? I saw your Josh Talks video from Dell to TrioTree. So, can you tell me about your journey? Why do you do what you do? Why healthcare suddenly? You are working with Dell and then you decided to jump into health.
Yeah. So I've been in healthcare for all the while. I mean,
Oh, okay.
I passed out of college in 2000, and when I passed out, there was a Y2K ordeal where people they're battling getting jobs. It's primarily in IT because of the Y2K problem, and hence my campus hiring got delayed.
Oh, okay.
And I mean, I used to not do anything, just sitting at home because the joining was delayed. And incidentally or accidentally, destiny had something else in its mind, and I joined Max Healthcare as a trainee. I mean, and I remember that was a time when people used to ask me that you have done computer engineering, what are you doing in hospital? And from that time, I started loving healthcare. And I've been in healthcare IT since then. Even in Dell had bought a company called Dell Services. It had bought a company called HP Pero, which became Dell Services.
Mhm.
And they were implementing a solution of EHR, which was a US based EHR, all across one of the big private chain. So that was the opportunity that we saw. And they were trying to implement a US based EHR product. We said, why don't we build something of our own? So this all Make in India started in 2011, much before Modi ji actually gave that slogan. So we started at a very small, I mean, 6 by 6 room, thinking that let's try to do it, whether we don't know whether we'll be able to do it or not, but let's try to do it. And then gradually we all came full time in 2012. We were bootstrap. We did not go for funding because it was more driven by passion. All those things that we see more of a patient. And I say this to everyone that education and healthcare, whether we like it or not, it actually touches everyone in one form or the other. I mean, you are from the media industry, I'm from a tech industry, but at some point in time, God forbid, we all would be patients. Yes, we'll
You are
walk into the
absolutely.
hospital. So the healthcare delivery is about everyone involved, not only it's not. And now with COVID has taught us that healthcare is not only in that closed walls of the hospitals or the clinics. Plus, it has got amplified because of the mobility phone. With the mobile phones, now your records or your tests, everything is actually along with you. Hence, I mean, I'm more into this as a passion. I call myself healthpreneur
Mhm.
because healthcare is something that you can do so much in healthcare. Any small thing actually can contribute to someone's well-being, someone's life.
Yeah, so true. So we hear a lot about digital transformation, right? What is the difference between digitization and digital transformation? If you could elaborate on that.
Okay, digitization is nothing but making the records digital. So doctors prescribe on a piece of paper, you scan it and you keep it. That becomes digitization. Digital transformation is when there are multiple departments gets impacted because of this change, and you do away with some manual processes. I'll give an example. I mean, the reason a lot of hospitals started the use case that we took, that okay, let's keep a copy of the scanned application, or let's keep a photograph so that we can remind the patient that you have a follow-up appointment. Yes, there is I mean, the trigger could be because of revenues, or it could be from a patient care, whatever it is, or a patient engagement. But essentially what you're doing is you're just doing a digitization. Now let's take for digital transformation. that the doctors are putting everything in the system. Patient has an app. This software is linked to the call center. Doctor says that take these medicines and follow up with me on 15th of August. Automatically on 13th of August, there's a notification on the patient app. The doctor had asked you to come for an appointment. Do you want to take an appointment? This goes an alert to the call center on the 14th that this patient has still not taken appointment. Do you want to schedule that call? Calls are scheduled automatically. So this is what digital transformation is. The process which was manual, suddenly you have made it automated, and this goes beyond multiple departments.
The
So
entire workflow gets affected, basically.
absolutely, absolutely.
Okay. What are some of the biggest misconceptions among hospitals about, digital transformation? Because when I did a story like probably 10 years ago or 5 years ago, so most of the hospitals were reluctant to spend too much on IT, right? Their IT budget was very limited. And one of the few things that a lot of people told me was about, interoperability. Like, different people create different software. You have a software
So
for pharmacy, you have a software for billing, you have, a different software for doctors. So, there is no connection. Everything sits in silos and you're not getting any sort of useful benefit from it. Has it changed now? So, how does it work now? Like, if you could elaborate, because most of our, listeners or readers are CXOs of hospitals who want to sort of invest in tech right now.
okay, so I mean, if you look at you spoke about how things were 10 years back.
Mm-hmm.
One of the things which has actually triggered digital transformation is COVID. So in healthcare industry, we call BC is not before Christ, but it is before COVID and after COVID,
Okay.
because things have changed. And if you look at any digital transformation, it is more driven by people. What is the need? Let's take the jump of the UPI or the financial transactions happening online. The need was during COVID, I can't travel. I need my stuff here. Even the currency I don't want to touch because, again, the contact I want to, that triggered, that amplified the digital transactions that we started happening, and then UPI and all payment gateways. Same is for healthcare, because COVID taught us that it doesn't matter where the patient is, it doesn't matter where the doctor is. You patient will have to give some tools to the patient where he can upload his records so that someone sitting maybe 1,000 miles away, a clinician can look at those records, do a face to face, and do a consultation. So teleconsultation, video consultation has been in India, telemedicine has been in India for last 30 years. But that got amplified during COVID. And now that has become a norm, that has become the way of life. Also, by and large, if you look at the patient of the healthcare, the way it has evolved. I mean, 10 years back, we used to go when we were sick, then we used to go to the doctors, which is what was known as episodic care. Then preventive care came into picture, means even before something happens, there after 40, every 6 months, these are the tests you need to do in a preventive way. The patient, and that is the reason if you look at all the labs, diagnostic chains are mushroomed around, because there's a business, and the business is that there are a lot of patients sitting at home doing online transactions. They want to get the test done on a preventive basis. So that has also triggered healthcare. Now, if I am sitting at home getting my test done, my records should come to me. I will not go that, okay, you send me the person. Now you will not send someone else with the paper records. So all of that has triggered this thing. And also, if you look at again the hospital landscape in India, there's a lot of private equity investment coming in. And we all know, I mean, of course, one of the things is that it will elevate the patient care. More hospitals will come up. All that is given, of course, but it's a business. People is funding money. They're looking for a return, and there's nothing wrong in it. How will the return come? Return will come not by hiring more doctors. Yes, that is important, but in a country where there is one doctor for every 1,000 patients, you can't suddenly have more doctors. Only way you can increase this is by using technology. So instead of having more doctors, we'll make doctors' time even more precious. And in that time, we'll get more patients. We'll use video consultations, optimize the time.
Mm.
We'll reduce the patient waiting because patient engagement is equally important. And the reason patient engagement is important or patient experience is important because I have got a choice to go to X hospital, which is funded by YPE. I also have a thing of going to a hospital, which is funded by B. Both are equally good. Now, both hospitals want a share of the pie. They want me as a patient to come to their hospital. And the only thing that can actually make a difference is the patient experience.
Yeah.
If one hospital reduces wait time by 15 minutes, I would prefer going that because time is money.
Yeah.
Plus, I as a patient, because I'm used to using a different delivery models for Book My Show, Zomatos of the world, Paytms of the world. If I don't see these benefits in other hospitals, then I have to stand in the queue to get my bill.
Yeah.
Then I'm worried. Hence, all these these are external factors, but these are all triggering digital transformations. And hospitals are willing to invest. And I'll also say the same thing. This problem is not the same across India. I had heard this thing that is desh mein do Bharat baste hain. There are two, one is India and other is Bharat. And that is a reality. If you go to a tier 1 town, these are the things that I spoke about. But for a hospital, there's a lot of untapped market, so to say, is in the tier 2, tier 3 towns. Now we know a lot of, if a doctor from a tier 1 hospital goes to a tier 2 town, because we want referrals from that place, my entire 1 day or 2 days is gone. Can we do something using technology that I don't have to travel 5 hours in a day, but I still can be present there? That can happen using technology. So there are a lot of external factors. There's a cutthroat competition which is happening. Plus, post-COVID, the patients have become more, I'll say, knowledgeable and conscious about their health. Hence, all of these is triggering the digital transformation and hence more investment into IT.
Okay. But what about resistance from doctors? Doctors might use iPhones and iPads of the world, but when it comes to, tech related to healthcare, they're usually very doubtful about it. So the thing is, if you go to a private hospital, the maximum face time that you get with a doctor itself is like 2-3 minutes max, right? If you go to a specialist. So is the biggest challenge the resistance from doctors or generally the workforce to implement a solution?
Yeah. So I'll approach this question slightly differently. You had asked that what is the biggest myth in healthcare?
Yeah.
And the way I look at it, the biggest myth is that doctors don't want to use the system. I look at it differently. They want to use it, but they want to use the time judiciously for the patient care. They want to hold the patient because India culturally is different. If you walk into a doctor's room or a doctor's chamber and he doesn't look at you, he just talks to you and looks at the system and does the entire typing, gives you a handed prescription. Vis-a-vis, the doctor actually holds your hand, looks at your eyes and talks to you. So culturally, we want if I come out, if the doctor doesn't even talk to me and looking at my eyes, I say, "Arey, इसने तो छुआ भी नहीं मुझे. क्या ये doctor ठीक नहीं?" And there's might be the same. Culturally, we want doctors to touch us, feel us, look at us, talk to us in detail. Hence, it's not that the doctors don't want to use the system. There is no resistance, but they want system. It should be seamless. It should help them what they want to do, which is patient care. Hence, if it is intuitive, if it is easy, it will be better. And that is where the newer technologies actually is helping now as part of in our hospital and also as part of our application, we have introduced ambient AI, which
Yeah, they can
which
listen and then give you a summary.
yeah,
The
it's just
solutions.
the conversation which is happening between the patient, the doctor, and the attendant, and it could be any language. The system will automatically listen to all this and summarize as to what it is. Doctors can just do a pick and choose, and they're done. I mean, coming back to your question, it's not a resistance,
Mm.
but it is more how will the system help me? Because I have back to back OTs. I have to finish in 45 minutes. Now, if you are introducing a technology which will tell me that, yes, I will take 1 hour, 30 minutes for what I used to do it in 45 minutes, then there's a problem. And also, this is also contributed to the new generation of doctors which are coming in. Let's understand for a doctor who's practicing for 40 years, he has written his entire thesis with hand. So he's emotionally attached to that as well. Vis-a-vis the new doctors, they're doing entire thesis with Google and laptops and everything. So they are pretty comfortable with this. So things are changing for sure. I remember the conversation we used to have 10 years back was, my doctors are not going to use it. Please, we'll not even talk about it. Now the conversation is, can you ensure that the doctors don't use more than 3 minutes on the system? The rest 7 minutes, they have to talk to the patients. So that is the change in conversation that has happened.
In terms of budget, right? How much do hospitals usually allocate for IT right now? In terms of percentage, 10%, 15%,
Oh,
or
no.
is it more than?
Much lesser than that, in fact.
Okay.
Much lesser. But again, I will look at the positive side. This is changing. The large cost of the any hospital is the biomedical equipments, the CTs, MRIs, the C-arms, the OTs,
Surgery,
the
yeah.
robotic surgeries and all. And then the doctors, the salaries, the consultation fees, so on and so forth. IT is still a small portion, but that portion is slightly becoming bigger. And also because we see a convergence which is happening across the various departments, it's all converging to IT. Now, the robotics, or we talk about OTs, and also this, the trigger for this is it's standardization of care, the quality of care. Now, what differentiates a hospital A versus hospital B? I'm NABH accredited. Okay, I'm also NABH accredited. I'm JCI accredited. I'm also JCI accredited. I followed digital health standards. Okay, I also follow digital health standards. So the things are changing also because of any time that you go for these, you need digital technologies, and hence the investment is also increasing. If you want doctors to use it in the OT, you will have to give them a tablet there or a wall mountable screen there so that they can look at the CTs or MRIs there itself. If you want the doctors to use it on the patient bedside, you have to give them a tablet. If you want nurses to use the documentation and do the quality checks of right patient, right time, right drug, right dose, and everything, you'll have to give them a cart which will they take the laptop next to the patient bedside. So I mean, again, there is no end to it. So I will not say that everyone will have this. Not all hospital across India will have everyone given a tablet to all the clinicians, or every hospital will have a cart. But things are changing. They were used to have two systems. Now they've allocated three. They have, instead of giving, I mean, or maybe two systems and one laptop. So that laptop is mobile. So the investment is growing. Plus, the investment is also growing on technologies of AI we spoke about, of auto capture of vitals, because that's also mundane thing that the nurses will have to capture. Can we use technology that automatically the vitals can be integrated from the monitors? And one of the trigger for this thing is, I mean, this also should be covered in the why hospitals have started looking at this as a digital transformation is also fear of litigation. 10 years back, because as patients or as customers, so to say, you're also not aware of about our rights. Used to look at the doctors and say, "Doctor to Bhagwan hai." It's not that anything has changed. Now the perception has changed.
Yeah.
I mean, I have come, they are taking money, they have to value me. And if there's something wrong, I can go to court. So because of fear of litigation also is actually forcing the hospitals to ensure that they do the digitalization plus the use technology so that everything is recorded.
Yeah, the doctors are so scared now. that, even if you need an ultrasound scan, right? So my doctor is telling me, so if you think it's very painful, you can go for an ultrasound scan. So it's like, doctor, please tell me, should I or should I not? Well, it's up to you, whether you want to do an ultrasound scan or not.
One of the other challenges also is now because of patient use of technology is such that whether the doctor uses the technology or not, patient will use the technology.
Yeah.
So I was talking to a very renowned doctor, and he was telling me that nowadays we treat the patient and patient's knowledge that he has actually acquired through Google, both of them, because he would have done his own exercise, and now he'll come back and question doctor why this, because Google is saying this. And the moment he'll step out, he'll just scan the prescription, upload in ChatGPT or Claude or Grok or whatever. Then random suggestions will come, and then the patient will judge whether the doctor is good or bad, or they're doing it just for making money, or do I really need it? So hence, this is also a trigger that let's document and keep it that I have told the patient. They have also become slightly more judicious because of the scare that social media is such that they might go and patient might go and put anything on the social media. He did not even look at me and prescribe something. I put this in ChatGPT, and ChatGPT says this is not required. And there's a reputational damage now.
Yeah. What are the different forms of AI solutions? You mentioned about ambient AI, right? What are the other solutions that hospitals are using? Do they use generative AI?
So there is generative, there is agentic, there is cognitive. So for all of these, there are solutions which the doctors are with the hospital is using. I'll not say the hospital using across in some capacity or the other, in some form or the other, different levels of adoptions, but they are. And now, discharge summary, if your entire patient stay is automated, or all the notes are in the system, all lab results are in the system, radiology scans are in the system, then why do I need to spend 45 minutes building the discharge summary? Why can't I use a generative AI tool to just generate the discharge summary? The other thing is now agentic also. Okay, if I get to know, instead of going through the patient record on the EMR, clicking here, there, and why can't I ask that, okay, just like I go to ChatGPT and say, tell me, it's raining outside, what should I eat at home? I can ask anything, right? Same thing is the AI prompt, which actually there are doctors going to the patient record and say, I don't want to go through the entire record. Just tell me which are the abnormal lab results in last 24 hours. Was there anything that I need to be cautious about? So all of that will come onto the system automatically. That's more agentic. Cognitive is again, the patient might be coming from outside, scanning the reports, taking his, not because everything is not automated. I might be carrying from some other hospital where things are still manual. I'll bring those things, and it is there. It will be scanned. Now, either I go and scan and read everything, or the AI actually scans and gives me a synopsis. So there are a lot of
So these
lot
are
of
the
things.
different forms. Okay.
Yeah, and they are again. I'd say India is a huge, is a big country. We can't generalize saying that this technology is being used all across.
Primarily in cities, right?
But things are changing. Even in tier 2 towns, in tier 3 towns also, maybe a smaller portion of doctors are still using voice to text. Because, and also the trigger is one smart doctor is already doing this in WhatsApp. I don't type, I speak, it gives me the translation, I send you the message. Why can't I use the same thing for my prescriptions? So, I mean, things are changing across India, but plenty to be done. But also because if you look at the standards like NABH and JCIA, those are also factors which are forcing the hospitals adopt technology. ABHA ID, ABDM, now has 3 milestones, M1, M2, M3. They are also, if you go to public hospitals now, there's a QR code. You just scan the QR code, and then you'd be able to register yourself using your Aadhaar, DigiLocker Aadhaar, and then ABHA ID gets created. Even in tier 2 public health setups, So things are changing. NABH has said that now that is a mandatory thing. Now I'm forced. Okay, how do I'll have to give, because also the pressure for the patient. If I have done it at the hospital X, if I go to hospital Y, I'll say they are there. I don't have to stand in queue. I'm doing it there. Why are you not giving me that option? That also forces. Okay.
You work with Rajagiri, right? Would you be able to give an example of how you implemented a particular software or a solution? It could be even AI or something else. And it sort of really made an impact on the patient experience or generally ROI of the hospital.
Yeah. So I'll take two examples. So Rajagiri is a 600-bedder hospital, JCI accredited hospital, and where occupancy is more than 90%.
Mm.
And when the occupancy is more, when the footfall is higher, every patient gets impatient. When they say someone else getting services and they have to wait. So we embarked on a project, we call that as a Rajagiri 2.0, where we said, let's work on patient engagement solutions. Let's try to reduce the wait time. And today we have introduced kiosks for self-registration. There are QR codes. You can scan the QR code and do the self-registration. Then on the mobile app itself, you can do a self-registration. Now the point is, the patient is not waiting. I have options. I don't have to wait. I can do my registrations of our own. And today, after 6 months of implementing, no, 9 months of implementation, there's no registration counter at all. There's a huge saving for the hospital now, because real estate is also a challenge.
Yeah.
Now that area can be used by something else. Plus, the other option is, one was queue management. I reduced the patient wait time there. That is, for example, sample collection. And traditionally, in all hospitals, by and large, all hospitals, you want to get your sample collection done, you go with your bill, they'll give you a token and tell them you wait. Now you get a token 21. You ask them, okay, which is the token which is running? They'll say you 7, you have to wait. Okay, how much time? You have no visibility whatsoever. If someone else walks in and that guy knows someone, he might go inside and I have no visibility. And this token has got no meaning or no relevance whatsoever. It's just a number for me. What we did there was, the bill had a QR code. We put a mobile app there. We said, you just scan your QR code, your number will come on the display there. And it will also tell you tentatively what time.
How much time? Waiting time.
Tentatively waiting time. Now I have that visibility. Okay, tentative waiting time is 7 minutes. There is total transparency. It's not that you can sneak in someone else. But in hospitals, there can be emergencies. Let's understand that the reality for that. I mean, I can't say that I want to do transparency so everyone follows the same. No, if there's a critical patient, he'll go first. But if that is the case, someone decides that this patient is critical, is an emergency patient, hence need to give in preference. Automatically, his name will also come on top, but will come in a different color and say it's an emergency patient. I have a visibility. If I see someone else being sneaked in the door without even I getting any information, I'll feel that, no, I mean, they're biased against me and they're purposely making me wait. With this, it's an absolutely transparent system. And there are a lot of things. I mean, in OTs, we have put a display there. In OTs, one of the challenges also is, let's understand the psyche of the attendants. When the patient is being wheeled inside, they only know the patient is inside. What happened? Is the surgery still on? Have they moved from pre-op to OT? Is the surgery finished? Have they moved to post-op? No visibility. Now we have put a display there. And it's all happening on a real-time basis. I am assured that, okay, now the patient is in post-op, means surgery is done, recovering. Still, the patient, the surgeon will come outside. I'll have a discussion how the surgery is, everything fine. But at least I have that visibility. Otherwise, I'm doing nothing in dark and just praying. So these are a few things that we have undertaken, and actually it has helped bring in transparency.
Yeah. And that actually gives a lot of relief to the patient's family, right? Because I have waited outside and like the same thing. You have no clue when the surgery will be over. And then you can't like really keep asking also multiple times, right? So they will say, if everyone is inside, we'll inform you after the surgery is over. That will really make
Recently we introduced, because Kerala as a state, there are a lot of patients who have lot of people who have migrated to Gulf countries and other countries, and their parents are still staying there, but kids are outside. The the kids are still worried about their patients, their parents. Now they have got some records here. The kids there, they want to have a reference to that. They want to look at that. So we've introduced an option in the system where records can be based on the consent of the patient. It can be forwarded with a OTP to their own kids or attendants or whatever. It goes to them and they can. Now, if and so this is pure more of a clinical. Okay, but let's look at, I'm sitting here and someone known to me, or maybe someone in my family is admitted at Rajagiri. I receive an automated SMS saying that your bill is X, your deposit is Y, you need to give more deposit. I don't have to go there and pay now. I can just click on that link and pay. Small digital initiatives, but gives a lot of comfort. It has saved me a lot of time.
What about discharge time?
So, again, we had undertaken the discharge time reduction as one of the projects within. And let's understand, when the clinician comes and says this patient is fit to be discharged, there are 7 or 8 more departments that need to do something before the patient is discharged. The billing department, the insurance department, the nursing department, the blood bank department, the OT department, the lab, the diet department. All of those need to interact. The pharmacy, and it has to be sequential. So what we have done is we have launched a dashboard called RTM dashboard, real time dashboard, and we have put it in all the floors. The moment, and we have defined a time for amber. So I say that these activities need to be completed X minutes after doctor has said this. If within that time it comes as green, the moment it approaches more than that, it becomes amber. More than that, it becomes red, and it's visible on a real time basis to everyone in that ward or to relevant departments. Now, just earlier, the challenge was doctors have written in a piece of paper, the patient is in the 5th floor, doctor has put that there, I'm in basement, I have no visibility of what is happening. Now everything is online. Seamlessly, I get to know. And it is also showing that now mine is green, but it's going to be amber. I better act fast. So this also, and again,
how would you be able to give a number in terms of how many hours have you been able to cut down?
So earlier it used to even cash patients and cash and credit. The reason, because credit patient, you have to give the final thing to the insurance company. They'll give you the approval. That also we have integrated through a third party, that now seamlessly I don't have to do it in the system. Automatically system will take all documents and send it to them. The moment the approval comes, it will come automatically. I don't have to keep standing next to my phone or my email to know whether the pre-approval. Automatically it will put the system. So that is for cash. So I'll tell you, before we embarked on this project, cash used to take more than 3 hours. Now we have reduced it to 1 hour 15 minutes, 1 hour 20 minutes. Trying to even bring it further down. Trigger also is because, like I said, the occupancy is more than 90-95%. So I want to do it from a patient engagement perspective. Now patient might have waited for 7 days in the hospital. The moment doctor says you are fit to be discharged, I feel I want to go out now, because no one is going there for fun. So that is one. And secondly, also once the patient is discharged and vacates the bed, that can get ready for the next patient. Some patient who's waiting downstairs at the admission counter. So it helps both.
Another challenge when it comes to healthcare from a patient's perspective is how transparent is the billing, right? Can tech address all these things?
So, I'll tell you, you have to understand that fundamentally and culturally, we are different than US. Culture is slightly different. But having said that, can these things be addressed through technology? Yes. Can we bring in more transparency? Yes. And that is the reason that you say more and more hospitals are going for a package-based billing that will charge you X, irrespective of what the thing is. But let's also understand that God has created this body is fairly complex. You can't have one size fit all. At times, there are complications which doctors were unable to comprehend. And I'm sure your question is not that whether you have overcharged or undercharged. Can you actually give that trust to the
Yeah.
patients and their families that whatever you have charged, you have done it fairly?
Yeah.
That is where technology helps, because on a real time basis, when you see that I'll just give an example. When you see on the screen that the patient was in OT for 7 hours, and then you go and tell the patient that it was very complex. We actually started doing the surgery, then this complication happened, this, that, and hence we'd be charging more because the patient was in OT because he has used OT for longer duration, gases were used. The patient would be okay with that, because that communication, that information needs to come. Large bit of distrust happens when there's no communication, and only thing that you are aware, or you get to know things when you have a bill in front of you.
Yeah.
Hence, on a real time basis on the app, you know what the current amount is, what is being used. Then a lot of these things can be reduced.
As a CIO, right? You work with two hospitals. What are the things that you can actually take a call on? Like, if you want to buy a software, is it like more a clinical decision, or do you need to get approval from the board as well as the CEO? How does a day in the life of a CIO of a hospital look like?
So, see, IT remains used to be a support function. Now it's a strategic function within the hospital. Can I decide a software? Yes, I can. At these hospitals, I can tell you, I can decide. So there is nothing called that X is the budget allocated, you can only decide. But if you take a step back, it's not about buying a software. It's about getting it implemented and being used as well. And for that, buy-in from the respective department is required. Hence, what we generally do is we onboard them as part of the entire journey. These are the three vendors that we're evaluating. These are pros and cons. You tell them the advantages, disadvantages, and the cost is primarily a discussion between the CFO and we tell the user, unless until there's a huge difference in cost. We don't want to buy something which they don't use. At the same time, if I go to buy a car, I can buy a Maruti, I can buy a Honda, I can buy a Toyota, I can buy BMW as well. So it's not about buying the car, it's about affordability as well. But generally onboarding the department earlier in the game, it helps, but primarily the decision can be taken by me in consultation with the CFO and also doing a total cost of ownership. But we also understand that all IT investments might not have very tangible benefit. There could be a lot of intangible benefits also. Patient experience, there is no tangible benefit for that. Patient experience, there's no tangible benefit for it. Generally, we do all that we do a risk. Will the doctors use it? Yes. How many percentage do you think will do it? So we do that work prior to getting any solution approved.
Okay. So in the next 10 years, what do you think will change in India in terms of health tech and the sort of solutions that hospitals use?
Look at India in last 10, 20 years. We see India providing best medical resources, whether it is nurses or doctors. We are actually sending it to other countries or outsource IT services, primary IT people going to US or UK or even BPO for that matter. And I can tell you with conviction, like UPI, we built it and now we are selling across the globe. Digi Yatra, we built it. And I know I traveled to multiple countries. I have not seen such seamless travel anywhere else. So next 10 years in healthcare, we are going to build tools which the entire world will use. It has started happening now. Even with medical devices, India is the best place because of economy of scale to test those products as well. I remember for one of the hospitals evaluating a product, AI-based solution, that you bring this thing and you can do ultrasound anywhere and this, that. And then I asked that vendor, okay, you do one thing, leave this device here and come back after 2 days. And it did not do anything on that device for next 48 hours. When he came back, it had a lot of dust on top of it. And he started cleaning it. I said, sorry, please don't clean it. Now you operate and tell me that this will give you the same type of solution. That is the reality. In India, climate is such that not everything is air conditioned. There is pollution. That's the reality. And if we can build a solution which will actually work in that condition as well, and it will change the entire thing. So, and I'm not trying to be nationalist or I'm not trying to be, someone who loves his country, hence I'm trying to make this up. This I genuinely believe that healthcare and technology and products that we are going to build now, we're going to change. Because in US, you're doing 10 to 12 OPDs in a day and you're done. Here, do 100 OPDs in a day. Hence, technology and product has to be better and efficient at this scale. This is happening. I know of a lot of startups. So I'm a member of NASSCOM. I actually mentor startups as well. And I know of a lot of startups who are building products which are actually changing. And in the same context, you would have heard someone in close to Amroha. One guy, he has actually done the taxi, the flying taxi. He has one guy who has set up his own company and he has done what Amazon has been trying to do since ages. What Uber has been trying to do, that guy has done in a tier town in Amroha. Rocket, again, an Indian. These are few things to be take pride about. So he has done the skyrocket with what Jeff Bezos and Elon Musk are trying to do. Those guys have done it in India at maybe 1/10 of the cost. That is what frugality and those challenges in India teaches you. So I'm gung-ho about next 10 years.
Okay. Thank you so much for your time, sir.
Thank you. Thanks, Ron.